and am helping to lead the charge into telehealth.
And I'm Dana Hawkinson, infectious disease physician and medical director of infection prevention and control. And my morning message just echoes what Dr. Stites said. We have to continue to do these things. Let's try to take responsibility and continue to try and flatten the curve as best we can.
We're open.
This is Angie with KCTV5. Dr. Stites, question for you. Can you tell me a little bit more about this search planning that you're talking about? Are you trying to identify other sites if needed where you could treat patients, or what does that mean?
You know, what we're really doing is making sure our models are predictive of what we think is coming, and that will lead us to what we have to do around other surge planning. KDHE is really leading the effort for the state of Kansas. We're working with them, and then there's a twin effort over in Missouri. And our goal is to make sure we have enough beds for all the patients that could potentially be out there, and that's really what surge planning is. So I will tell you that at all levels we spend a lot of every day looking at the curve, looking at the numbers, trying to figure out where we are and what could be coming. I mentioned in an earlier session this morning, yesterday we had the remarkable opportunity to be on a phone call for critical care planning with the leading academic medical center in Wuhon, China, and one of the largest hospitals there. And so their leadership and our leadership were visiting about how have things gone, what's been like, how did you get on the other side, and we'll be talking with leaders from Columbia St. Presbytery. We have a call scheduled with folks from Italy. So we are trying to do everything we can to be prepared.
How many beds do we have across Kansas? Do you have any?
I don't have that. You'd have to turn to KDHE for that number. I don't have the ready number, honestly.
Do you want to update where we are with patients?
You know, I do. Did you have the numbers this morning?
Yeah, the numbers, I believe we have 18 patients in-house currently. 10 of them are in the ICU.
And 6.
6 of them are intubated, and the other patients that are not in the ICU are on a typical medical floor for treatment.
And we do cohort the COVID patients. That's one of the most important lessons we've learned. So we've identified specific wards for rule-outs, patients who are positive, and people who are in the ICU. And one of the things that has happened that by canceling surgeries and cutting back on elective clinic visits, 2 things have occurred. Number one, we have spared a lot of PPE, personal protective equipment. And number 2, we've created capacity. That was intentional. Our normal daily census right now should be 700 to 800, and we're about 450 to 500. That gives us 250 to 300 beds that we're prepared to take and have COVID patients in, and we know what beds those are going to be. We know where they'll be in the hospital and how we're trying to resource those areas. We've been training our staff to be ready for that. So that's, from our standpoint, those are the things we're doing for disaster planning, pandemic planning, and of a potential surge.
I hate to take up all the questions. Are there other reporters on this call?
Yes, this is Lisa from the Kansas City Star. Dr. Stites, could you tell us a little bit more about what you learned from your conversation with the medical professionals in Wuhan? Was there anything concerning to you, or did they give you information that you can now pretty much run with, or alerted you to something that you're not doing right now?
You know, I will say there was one thing that they had done that we had started to plan on that I think took a little higher degree of importance when we visited with them. And that was actually sort of a triage area for critical care. There's one for the emergency room already. We have that done. But the one for the critical care was a rule-out unit in which patients who were critically ill or had to be intubated and you didn't know their COVID status yet, patients would go to that unit, and then if they tested positive, they would go to the COVID ICU, and if they tested negative, they would go to the standard medical ICU area. And so I think that was helpful in how they thought about that, so I think we learned from that. What I do want to say, and one of the things we thought was some of the best messages we got, first of all, we're thinking along the same lines that they would have said, hey, this is what you need to think about, and credit to them for putting a lot of that out prior to this. But the other thing that was interesting, you know, in China, before folks understood what was going on with the disease and how it was transmitted, there was a coronavirus and all those things, there were a number of medical professionals that became ill. And what we found, what we heard from them very clearly is once they put the right PPE in place, which is the same recommendations we're following, the same things the CDC said and the World Health Organization says, Once we had that in play, once the Chinese had that in place in Wuhan in this hospital, the number of transmissions that went from patients to healthcare professionals was zero. And I think that's the really important message. Yes, there are healthcare professionals who become ill because it's in the community, and you're going to have community-wide spread. You don't wear the same PPE when you're out in the community as you wear when you're around other people who are positive. But if you wear the things we're asking you to do and do the things you're supposed to, you don't get sick. The second thing that we heard was, they did a lot of contact tracing and then having people stay at home and being really regimented about that. Now, we don't do that in the United States. Our testing isn't as good, and we haven't been able to get everybody's home. So all of our alternative is to shelter at home. And that really works because in community spread, which is where we are now, you don't know who's positive and who's negative. And so the answer is stay at home and don't have contact with other folks. Don't be grabbing those dirty doorknobs because you don't know who's positive and who's negative. So the best thing you can do is shelter at home and not have a lot of social contact. Even with your friends, you think, oh, they're fine, they're healthy. Well, you don't know that because people can start spreading that virus for 24 to 72 hours prior to them becoming ill with fever or cough or what other symptom they're having. So because you don't know, then you might be spreading that virus. So do what you do know, which is to try and stay at home. And I think that was the other thing, that's what helps stem the tide in China. It's also the same thing in New Rochelle, New York.
I have a question.
One.
Everybody's talking about high, medium, or low risk, identifying communities. And I know we can't completely trust the numbers because we're still waiting for kits. We can't do a lot of testing. We're doing some testing. What is your sense on where we are at, where the risk factor is?
Yeah, so what we try to do is model what percent of the population we think is going to be sick over what period of time. And we've worked with KDHE, our own internal team. We've worked with the school or the School of Medicine here and the Department of Population Health, as well as national figures. And there are a lot of tools others have put out on their web to try and estimate how this will come about. And we look all of that and try and figure it out. And to be bluntly honest, with a lack of testing, it's a little hard to know where we are on the curve. What we think is we're on the ascending limb of the curve. We're early. It's what I said the last couple of days, and I'll change the analogy from football to baseball today. We're still in the first inning, and we won't know where we are for a little while longer. And I would say in 7 to 10 days, we will have a much better picture. And it'll start to emerge over the weekend. Over the last 2 weeks, we've gone from one hospitalized patient, and today we have 16. And so we know that number is accelerating, and we know the number of intubated patients and ICU patients is accelerating. Mm-hmm. So we think we're on the ascending limb of the curve. What we don't know is if we flatten the curve or not. And it just takes time to do that. So if we have 5% of our population that gets infected, we're all prepared for that. If we have 20 to 25, 30%, okay, we're going to get stretched, but we can figure it out. We hit 40 or 50%, which is where New York is, that's going to be tough. And that's why social responsibility is so important. And the less infection we have, the flatter the curve. But we want people to still stay healthy. So I'm just going to ask Keith, what percentage of folks, people still have to see their doctor, even if they don't have COVID-19, right? You still have other healthcare problems. Can telehealth be an answer to a lot of that?
Absolutely, Steve. We typically see between 4,500 and 5,000 outpatient visits a day as an academic medical center. In concert with our patients, we've been reducing that number by about 60 to 70% to try and keep our teams and keep our patients safe. As a result of that, a lot of those chronic conditions are difficult to manage because they're not taking a break, they're not staying at home, they continue to be an issue for all of our patients. And so as a result of that, what we're trying to do is figure out how do we start to meet those needs, and telehealth is a great option. The government has relaxed some of their regulations around telehealth visits and connecting with patients via video and audio virtually. That's allowed us to really ramp up, and so what was going to be about a 2 to 2.5 year process has turned into about a 2-week process. We've converted roughly 600 physicians into telehealth users. We've, in 1 week, I think, been able to put together just about over 800 telehealth visits for our patients. And over the next several weeks, we're hoping to provide over 2,000 telehealth visits a day so that our patients who have these chronic health conditions can continue to receive the care that they need, but do it from a safer environment in this shelter-at-home time.
And this is a game changer. I think it's going to change medicine entirely because telehealth has been loosened up so much.
I think so. I mean, I think, a lot of our providers have wanted this type of interaction with our patients for a long time. This is a great way for those folks who struggle to drive in to see us, or who have transportation issues or other problems. This opens the door for us to really change how we deliver healthcare in a much more rapid manner than we otherwise would have been able to do in the absence of a crisis.
Can't let a crisis go unwasted. If there's a silver lining to the coronavirus crisis, it will be around telehealth and our ability to reach out to rural areas which previously may not have had that level of care. Questions?
What kind of regulations had to be relaxed to allow this? And can you walk us through an example of a typical telehealth visit between, a patient and a doctor, for instance, someone with diabetes or a heart condition?
Absolutely. So initially, a lot of the regulations were centered around being about having to have an established relationship with the physician to be able to do telehealth, and there were some guidelines or requirements around location and geography for the physician and the patient to be able to connect via telehealth.
So you had to be in an office, and they had to be in an office.
Correct. In actuality, you really couldn't be. There wasn't a way to bill for a patient to be seen or for the insurance carriers to cover a visit that was not in person. And so with the relaxing of the regulations, we now have the ability to really see both new and established patients across state lines, regardless of our pre-existing relationship with them, and meet their healthcare needs. So a typical telehealth visit, as we're setting this up, involves getting our patients on a third-party platform called Zoom. That connects with our Epic ambulatory electronic medical record, known as O2. And we then are able to do basically currently a dual screen process where once the patient logs into the meeting, the physician logs into the meeting, and the two people then connect and talk about their condition. As we do that, we can document in the electronic medical record that is up alongside that video session. We have all the patient's information there for us, and we can discuss what their needs are. We still have the ability to order labs, order imaging, and do those kind of things in a virtual manner. In addition to that, we're offering home prescription service, and so we can connect them to our pharmacies and allow them to receive medications directly to their mailbox from our outpatient pharmacy. So we're really trying to allow our patients to connect with our teams, get the care they need, but do it from the safety and convenience of their own home.
And the cool thing, I mean, if you can say, well, my legs are swollen, so let's take it that they show their legs up on the Zoom camera. And I mean, there are obviously some things you can't do. And ultimately, we're hopeful that some of the smartphone technology will move forward and we can measure things like blood pressure and pulse and electrocardiogram and other things. There are devices out there for that now. It's not particularly widespread.
There are a lot of home kits or devices that can be used to capture basic vital signs like blood pressure, EKGs, and whatnot. I mean, even the Apple Watch now can capture your a basic EKG on a patient. So you mentioned the heart patients. There are home glucometers that check blood glucose levels at home. All that information can be done and relayed back to the physicians as they're treating the patients over the telehealth visit. So there are a lot of things that we can do just based on sight and reported information from the patients. We're working with our supply chain and pharmacy teams to identify what those kind of best practice kits are for our patients to be able to use at home and trying to make those available over time. As I mentioned, we've kind of ramped this up over about a 2-week process, so it's still in its infancy, but I think we'll be able to see a ton of patients and meet some of their most basic healthcare needs within the next couple of weeks, and hopefully continue to advance this over time to be even more sophisticated with the care we can provide.
Questions?
What challenges are there? This is Taylor, Channel 41. What challenges are there with not to be indelicate, but older patients or patients that are not quite so tech savvy? I mean, I know what kind of.
Sure.
I have to walk my mom through how to use her iPad over the phone. Like, what kind of possibilities are there for older parents that may not be as tech savvy for telehealth?
Sure. So keep in mind, telehealth is one tool. We also have we also have audio visits where you just talk on the phone, which is called a virtual check-in. We have electronic visits, which you can do over the internet. All of those will be rolling out over the course of the next several days. If patients are not tech savvy enough, there still is the in-person visit option. So that has not been completely removed. But as we discussed, the goal here is to reduce the number of those patients and their risk. The interesting thing is, at least in our initial experience, we've had a lot of older patients who are extremely satisfied with this because they're actually more tech savvy than we give them credit for. And a lot of them are so thankful they don't have to drive in, figure out either the big city traffic or navigate from our parking lot through our big, enormous clinic structures to get to a clinic. So they are super thrilled with the idea they can sit in their home and connect to us via iPad. amazingly enough, most of them have been doing FaceTime with their family and their friends already. And so if you can do FaceTime, you can really do telehealth. It's really that simple.
And the truth is, my 87-year-old mother-in-law does this and will teach me a few things about that.
More than likely.
Yeah.
Are we using that for COVID-19 patients?
We are using it sometimes for COVID-19 follow-ups. And you want to talk a little, touch on that for just a moment, Keith?
Yeah, so telehealth isn't just for the outpatient world. We actually have active telehealth use in our emergency department. We're connecting with our skilled nursing facilities that we work with and partner with across the city. We are beginning to roll it into our inpatient environment, where patients who are COVID positive and need a consult from a different specialist can do that via telehealth. So we don't have to use our PPE equipment for our providers to go into the room, and they can do it via a telehealth manner. And then lastly, we're working to try and connect our specialists and even our primary care docs across, and actually even our inpatient docs across the state. So where we have shortages of physicians, either from quarantine, from self-isolation, or for other reasons, our physicians can reach out into those hospitals and into those clinics and provide services for some of our partners and some of our other care providers across the state.
And Dr. Hawkinson, I know that we've even tried to put together a schedule for our ID team to handle some of these infectious disease questions for areas that don't have an ID doctor, because obviously that's a big deal for COVID-19 patients.
Yep. Certainly throughout the state, we are really trying to get our resources and our knowledge and our assistance to our providers throughout the state for this. Hopefully, a lot of those places won't have COVID. Certainly, there aren't a lot of cases in Kansas at this point further west of here. But as it moves forward, we can only anticipate that they probably will get COVID cases. In addition, there are still other infections. There are still other diseases that are going on as well. So we are trying to offer our services through that.
Next question.
I have a question about the PPE. This is Taylor at 41 again. Can you give us an instance, because we're seeing these horror stories on social media of places like hotspots like New York where people are having to wear trash bags and that kind of thing in hospitals. Can you give us an instance of, one, how close local doctors are to that kind of doomsday scenario, having to do that, and two, what the usage rate is for that kind of stuff? Like, is this something you guys put on at the beginning of the day and you can keep basically the same gear on all day, or you're having to switch out to 3 or 4 different sets throughout the day?
So I'll let Dana take that part of the question. I'm going to just hit the thing. The base of the question is really all around surge, right? Because again, if we have 5, 10, 20% surge or infectivity rate, which gives you one curve and one set of numbers for how many people in Kansas City are infected in our metropolitan area, then I think we're pretty well prepared. I think New York got stretched because they have had so many people hit so fast. A couple of thoughts. A, supply chain in the United States is ramping up. Historically, a lot of these supplies did come from overseas. And so when the overseas shipments got cut, or because in China they needed so much internal material, then it was difficult to get to the United States. So at this point, I think we have an advantage of being in the Midwest because we will be relative latecomers to the coasts. You don't see the same story playing out in California and Seattle. You did a little while in Seattle when they initially got hit, but it's not like New York, and it's the difference in the infectivity rate in those communities. And I know you guys are tired of my saying this, but it is all about staying at home. If people will stay at home, which is what's happened now in Seattle and in California, then you will flatten the curve, and we will have enough personal protective equipment to protect folks from that. If we don't, then we're all going to suffer the consequences of that. Now, Dana, you want to talk about how we're doing how often people have to change and reuse as well?
Yeah, so we are still trying to conserve PPE, most notably masks, face masks. We are allowing for extended use for these face masks. So we are able to help conserve PPE in that way. At this point in time, again, we don't have an issue with supply, as Dr. Stites alluded to, but we don't know about the surge, and so we are planning for that. So we are allowing for extended use of face masks, reuse of other respirators such as N95 masks, which are very popular in the media right now. So we are trying to conserve in that way. We aren't being flippant with anything. We're trying to manage it conservatively, but also at the same time keep our healthcare workers safe and keep our patients safe. And by doing that and the conservation, I think we're able to do that. The main underlying thing, even with PPE, if you're not putting it on correctly and taking it off correctly and using good hand hygiene while you're doing it, you still have a chance to get infected. And so therefore, we really stress our training and our hand hygiene, and that's one of the main underlying premises of using PPE.
Questions?
This is Angie with KCTV5 again. How many tests are still out there where we're waiting for results? Because I'm hearing from people, and it's been more than a week, and they're still patiently waiting, staying at home, doing what they should. But can you give us a sense of how many tests are still out there and you're waiting for results?
Yeah, I don't know from other places. We're blessed. We were able to go live with our own internal testing this week, and that has shortened our backlog a lot. So we're around 12 to 24 hours, and that's better than what we were. Now, if the surge comes in like we expect, then we don't know if we'll have that many tests. We'll have to start having to go out to commercial and third-party folks, and I think that's been the issue, is we overwhelmed that system. Now, I think that the capacity is ramping up from places like Quest and ViraCore, LabCorp, and others, but the volume across the country and the region is really high, and that's what's causing the delay. Inpatients get their test results back in general throughout this crisis faster than outpatients, because if you're an outpatient, you're healthy enough to be at home, and inpatients, we just need to know if that's what you have or not, because we don't want to burn through the PPE if you're an inpatient if you don't have COVID-19. So the inpatients do move to the front of the line. The only way that this problem is going to get solved is that there are enough tests. And the only way to have enough tests is to have enough production of those tests. And so we just, the United States was just behind when this started around that point. And I think that we are trying to get the right number up there, but it's still going to be a struggle as the crisis moves across the country and there's surge throughout the rest of the U.S. population.
I also have one other question on a medication. Everybody's talking, and I'm going to mispronounce this, chloroquine. What's your guys' supply like there? Because we're hearing some people are unfortunately trying to shore up on it, stockpile in case this is the miracle drug. What's it like for you guys there?
It's not a miracle drug, but Dana.
Yeah.
Yeah, you know that. I know. That was just a comment. That was my editorial.
I would
comment,
like to echo that from you and from Dr. Stites. It is not a miracle drug. So it's hydroxychloroquine. It's typically a malaria agent, but it's also FDA approved for certain conditions like lupus, like rheumatoid arthritis. There is a very real issue. I don't know so much about around our region, but certainly around the United States, that there are people who need that drug for an FDA approved reason, that their doctor is prescribing for them, that are maybe not able to get a full supply because there is shortages. Currently in the hospital, we have a certain number of patient days that we have, and our supply is okay. But as we get more and more patients, and as we are trialing this drug on a trial basis with strict criteria, that supply may be depleted. Again, we just don't know what's going to happen in 5 or 7 or 10 days. I would like to point out, and Dr. Fauci pointed out yesterday as well, this is not a miracle drug. There is no proven data to support that this drug is efficacious for the treatment of COVID-19. Either you're getting it if you have the infection, or a lot of people now are trying to prescribe it if they think they've been in contact with somebody who has it, or if they think they may come into contact with COVID. He'd like to stress, yesterday especially, that there are significant side effects with this drug. There is no proven efficacy, and there are people who actually need it. So yes, we can trial and give it, but it has to be under strict criteria, and it has to be so that we can study it, to study the safety of it, to study the efficacy of it. And so with that, I think that, again, there's no proven efficacy. We are using it here at KU, at University of Kansas Health System. We also have some other drugs that we are trialing for our patients as well, but that is one of them.
What else are you trialing?
Well, there's also another drug, azithromycin, which is an antibacterial drug. That's been in the media. There has been remdesivir, which is a Gilead product, which has now They've even lessened the amount of people that can get that. We are still working for access to that. And then there is also tocilizumab, which is a monoclonal antibody. So those are the 4 main therapies that we are using on clinical trial criteria for certain patients.
And we have 3 of those 4 drugs here that we're doing today. Remdesivir is harder to get because there's been such a demand for it worldwide now, and it's not an FDA-approved drug here in the U.S. Questions?
This is Taylor at 41 again. I know how much time you guys spend on social media, but it feels like quite a few people have decided to use their Facebook login as their own medical degree.
Mm-hmm.
What misinformation are you seeing or are you hearing about on social media that is either most prevalent, most concerning to you, that is worth thinking whenever you see it? I'm basically asking you to help me win fights on Facebook whenever I go on.
Wow, there is so much stuff out there. I don't know where to start. I'm going to do the reverse. I'm going to say if the World Health Organization or CDC hasn't said these are the right things to do, then it's probably more legend than fact. And you know, you guys have heard me say this before in these conferences. There's fear and there's knowledge, and unfortunately, with this particular disease, because there's not as much knowledge, there's a whole bunch of fear, and it is dangerous. And so when you hear people start talking about, hey, this miracle cure, this is what you need to do, or look at this great new vitamin supplement, or we've heard that if you do things this way, you'll never get the disease, and you know, you just need to drink 27 beers a day and you're protected from coronavirus. Well, you know, those things don't work, right? Because if they worked, we'd all be doing them. There's a certain degree of paranoia, though somehow we're withholding truth. I'll tell you what, you give me a truth in coronavirus, I think all of us are going to say, let's go. And I don't think any of us are trying to withhold anything that we think is even remotely helpful. And that's why, as Dr. Hawkinson just said, you know, we don't really know if hydroxychloroquine and azithromycin and I can't say the other one, the monoclonal antibody and all the remdesivir will work. But we're trying all of it, right? We're trying everything. We are unturning every stone to try and figure out what old drug can be reapplied. So that's how we're approaching it, and it's pretty aggressive, and we're in phone conferences all around the world trying to figure out what others have done to see if there's anything at the forefront of knowledge. And what I would say to you is listen to the folks who are doing this and have done it for their lives. Listen to Anthony Fauci, the head of the NIA, the National Institute of Allergy and Infectious Diseases. The guy's been through AIDS, he's been through SARS, he's been through MERS, he's been through all sorts of things across the world. He is probably the most respected leader in the world around these things. Listen to what he's telling you. He's a smart guy. He's been there and he's done that. And all those internet posts, yeah, they've not been there. They've not done that. So time for one more question. I think then we'll have to probably go. I think we're already past time, so one more. Anybody out there? Okay, we'll do a couple of wrap-ups. Keith?
I think, you know, telehealth is probably the wave of the future for healthcare in general. I think it's the best way for us to continue to take care of our patients right now who still have healthcare needs at this time of shelter at home. I think we're striving to meet those needs, and we look forward to getting more of our patients and more of our team up on telehealth in the upcoming weeks.
Yeah.
Dana?
Continue to shelter at home, as Dr. Sale just said. Continue to social distance, physical distance. Stay home, wash your hands. It's hopefully going to be nice. Obviously, get outside. Try and keep yourself healthy. Exercise is healthy. Get good sleep. Get good nutrition. Those are the things that are really going to help you moving forward.
Remember, there's no place like home. Thank you all.